Yeah, hi, good afternoon from UAE. And I would like to introduce our first speaker, that is Dr. Sinem Iraglu from Turkey. And I am passing her the stage to deliver the speech on group experience in creating a patient safety culture with creative drama technique, a mixed method study. Dr. Shinem, you can now present your presentation. Thank you.
Thank you.
Please share your presentation and introduce yourself and present your research work.
Uh, okay. Can you see?
Yeah, we can see you and we can hear your voice as well. You can proceed.
O-
Thank you.
Okay. Thank you. Hello, my name is Sinem Eroğlu. Firstly, I want to give information about me. I'm from Turkey, but I am currently living Qatar with my family. I'm a nurse with a PhD. I have worked in many different positions, such as training nurse, infection control nurse, training coordinator. I have conducted nursing courses, a lecturer in many different universities. I work in nursing education, patient safety, qualitative researchers, innovation, and creative drama. Throughout my nursing studies, I have always strived to discover innovations. The study I will present it to you today is my PhD thesis, which I hope will contribute to the literature. Firstly, I want to start my presentations by emphasizing the words of one of my colleagues who participate in the research. We don't deal with car repair, we deal with people. This statement highlights the seriousness of the work that we, as health workers, undertake. I will start with the background of the study, followed by the purposes of the research questions and hypotheses, methodology results, and recommendations. We all know the definition of patient safety. We have talked many times. At least 5 people die every minute because of unsafe care. Ensuring safe health care begins with creating a patient safety culture. We must create a strong patient safety culture. So, nurses play an important role in this because they provide care 24 hours a day. So, we thought about how we can create a strong patient safety culture. As a result of our research, we found creative drama to be an important education tool for making changes. Through creative drama, you can understand the problems and learn the results of solutions by experiencing them. So, no study has been found that investigates the effect of using the creative drama technique on patient safety. When we look at the purposes of the research, we had 3 different purposes. The first was the general purposes. For this, we wanted to describe nurses' views, opinions, and knowledge about patient safety by determining the patient safety culture. We also aim to create a patient safety culture through patient safety precautions training given with the interactive theater technique and to reveal in depth the impact on the formation of patient safety culture based on qualitative and quantitative data. The second purpose was the qualitative purpose. For this, we want to determine nurses' opinions, thoughts, and knowledge about patient safety and to reveal in depth the reason for the obstacles in the formation of patient safety culture based on qualitative data. The third one, the third purpose was the quantitative purpose. For this, we wanted to determine the patient safety culture and the effect of patient safety pre-equation training given with the creative drama technique on creating a patient safety culture. So, for the qualitative phase of the research, we had 4 questions. These are: what are nurses' views on creating a patient safety culture? What are nurses' opinions, thoughts, and knowledge about patient safety definitions? What are nurses' views and opinions on medical errors? What are nurses' opinions and thoughts about error reporting? For the quantitative phase of the research, we had 5 hypotheses. You can see here. As we can see, this research is a mixed method study in an experimental, exploratory, sequential design. So, the research was carried out in a private hospital in Izmir between November 2019 and June 2020. The population of the research consists of 100 nurses working in a private hospital during the research period. You can see our research design according to mixed method. This method has 5 phases. First one is the collection of preliminary data. Second phase is the identification of participants. Third phase is providing face-to-face meetings. Fourth phase is providing training. And the last phase is the collection of final data. All nurses who accepted the research were included in the first stage of the research. The participants in this study were determined by the criterion sampling method within the purpose sampling method. To ensure the homogeneity of the group, nurse whose hospital patient safety culture score was below 60 points formed the experimental and control groups of the research. 37 nurses who met the criteria for inclusion in the experimental and control groups of the study. Individual face-to-face interviews were held with a total of 26 nurses in the sample group. 3 nurses who left the hospital and the research was completed with 23 nurses who agreed to continue the research. For the qualitative data collection tools, we used the patient safety culture semi-structured interview form. It includes 9 questions about patient safety. You can see here 9 questions. For the quantitative data collection tools, we used 3 forms. These are the nurse introduction form, the hospital survey on patient safety culture, and the post-training interview form. According to all literature in exploratory sequential mixed method design, the researcher analyzed 2 different databases separately. So, the findings were analyzed separately as qualitative and quantitative data. For qualitative data analysis, we used the MaxQDA 20 program in content analysis. With this program, we applied transcription of voice recording, thematic content analysis, creation of codes and subcodes, preparation of notes, reporting and analysis of codes and subcodes, and preparation of the visual content of the analysis. For the quantitative data analysis, we used the SPSS 15 package of program. For research ethics, We obtained consent from the Ege University Faculty of Medicine Clinical Research Ethics Committee, the private hospital where the research was conducted, and the nurses who agreed to participate in the research. In exploratory sequential design, qualitative results are presented first and quantitative results are presented later. So we will first see the quantitative results and then we will see first the qualitative results and then the quantitative results. This model code theory is about creating a patient safety culture with the creative drama technique. When the participants' processes of creating patient safety with the creative drama technique are examined in study, three main themes emerge. These main themes are patient safety definitions, medical error, and error reporting. When we look at the main theme 1, which is patient safety definitions, we can see a striking slogan, just doing no harm. This slogan reflects the summary of this theme. When the participants' definitions of patient safety are examined, three sub-themes emerge. These are thoughts on achieving patient safety goals, patient safety description, and patient safety goals. According to the participants, there are two subthemes for thoughts on achieving patient safety goals and 14 subthemes for patient safety description and 6 subthemes for patient safety goals. When we look at the main theme 2, which is medical errors, we can see the same striking slogan. We are not dealing with repair, we are dealing with people. This slogan reflects the summary of this theme as well. When the participants' definitions of patient safety are examined, two subthemes emerge. These are procedures and introductions and obstacles that threaten patients' safety in the unit. According to the participants in the research, there are 11 subthemes for both obstacles that threaten patient safety in the unit and procedures and instructions. This theme's summary slogan is, can error be bigger or smaller? What if I get fired? When we look at this theme, we see 5 subthemes emerge. Participants in the research state that their manager encourage employees to report errors and try to solve problems constructively instead of being destructive, but that there was room for improvement regarding feedback in the post-reporting process. According to participants in the research, the way of reporting was done in 3 ways: only oral, only written, both oral and written. For the incident reporting process, as stated by the 20 participants working in the clinic, when an existing error was witnessed or noticed, they were able to complete the notification process by recording the incident in the detail with the security reporting system. For the quantitative results, we can see these results. The majority of participants in the research are working in the intensive care unit. They are clinical nurses, have under 6 years of experiences, and have been working in the hospital for under 1 year. They are 27 years old and younger. They are women, have a high school education, and have weekly working hours of 49 hours. 87% of nurses receive training on patient safety measures. The same percentages of nurses did not report errors or incidents. 90.9% have direct communication and contact with the patient. For the experimental group, it was determined that there was a significant difference in 5 sections within the group. These are teamwork within units, manager expectations and patient safety improvement activities, hospital management supports for patient safety, comprehensive perceptions of security, and transfers in the hospital. For the control group, it was determined that there was a significant difference in one section within the group. It's only teamwork between hospital units. When the entire group comparisons of the nurses in the experimental and control groups were examined, there was a significant difference between the post-test averages scores of subdimensions of team working within the units, staff provisions, and non-punitive response to error. In this table, you can see the changes in the patient safety culture over time with patient safety measures training. The blue line represents the experimental group. The orange line is the control group. We can see the number of reported incidents in this graph. During the follow-up period from before the training to 2 months after the training, there was an increase in the number of incidents reported by the nurses. The increase is especially higher in nurses trained with the creative drama technique. When we look at the post-training interview form answers of nurses in experimental and control groups, we asked about the effect of education on perspectives on patient safety. It was the same for the experimental and control groups. It taught me that I should be careful and knowledgeable, and that seemingly small mistakes can have big consequences. We asked about the effect of training on patient safety practices. The majority of the experimental group answers experiencing the events firsthand, thinking about them, and emphasizing with them positively influenced people to be more careful. For the control group's answer was positive as well. When we asked them to rate the education activity and explain why, the experimental group gave the training activity a rating of minimum 7 points and maximum 10 points. Think it was fun and educational. The control group gave the training activity a rating of minimum 5 points and maximum 8 points. Think it was effective. When we look at the recommendation, while planning patient safety precautions training, more emphasis should be given to practices that will increase awareness of error reporting, and practical training should be provided. Studies using the creative drama technique can be carried out to increase intra-unit team communication, manager expectations, and patient safety improvement activities, and improve error reporting processes. Due to the confusion between the concepts of information security and patient safety, improvement efforts must be made in this regard. The nurses in charge of the unit hold meetings with the employees in the unit at regular intervals about the events that have occurred or are likely to occur in the unit and report the results through inter-unit teamwork. The quality unit provides improving feedback on patient safety targets by creating monthly reports to the units regarding errors in the units. Using creative drama techniques regarding reported or near-miss incidents in order to increase communication with the team and between units. In order for the incident reporting process to be known and implemented by everyone, remedial studies should be carried out regarding the processes, and these studies should be demonstrated with application steps. And in study where creative drama technique will be used in the field of health, the sample size should be increased and research should be conducted with employees in different professional groups. Sorry. Yes, you can see our researchers, and we have many others, but I can't add. If you would like more detailed information, such as the nurses' answers, I can send you the link to the document. Thank you.
Thank you so much, Dr. Sinem, for your nice presentation.
Thank you.
And is there any questions from the audience? If anyone is having any questions, kindly ask on the chat box, or you can unmute yourself and you can put your questions in front of Dr. Sinem. Thank you, Dr. Sinem. I think it's a nice presentation and there is no questions as of now.
Thank you so
So
much.
thank you so much. So we'll move to our next speaker, Miss Sandra from UK. And I am passing her the stage to deliver a speech on enhanced one-to-one care proposal for falls prevention. Welcome, Miss Sandra, and you can proceed with your presentation. Thank you. Kindly unmute yourself, Miss Sandra.
Oh, sorry. So I didn't realize.
Thank you.
Yeah, I said
Kindly
I'm
share your
currently at work, so I was
presentation.
trying to catch up.
Okay, sure. Kindly introduce yourself and proceed with your presentation. Thank you.
All right. Can you see me?
Yeah, we can see you and we can hear you as well. You
Okay,
just need
okay.
to
My
share
name
your
is
presentation.
I'm Sandra Fidelis, and I'm a nurse. So I need to also talk about the things I've done. So I've nursed in acute care in surgical units, in medical units, infection control, and thereabout. And I recently moved to the UK to have a bit of an environment and shift and see how it's going to be like. And it's been all right all this while. So currently, I'm doing my master's degree in University of Central Lancashire, and we've done several courses, one of which is practice development. And under this practice development, I wrote about enhanced one-to-one care, a proposal for falls prevention. Now, the reason I had to look into this particular topic was because of the numerous false incidents that we have been recorded, especially in elderly care, because currently I work under elderly care and see our patients falling every time and again. And then one thing I noticed is that whenever they have these false incidents, it really affects their mobility. So it makes them decondition really fast, because we know that once they're in the hospital, they tend to decondition, and the more they remain in the hospital, the more deconditioning happens. Now, when they fall, it becomes really intense for them, and you
Excuse
see
me,
them
Miss
deteriorate.
Sandra. We are unable to see your presentation. Can you please kindly share your presentation?
Oh, I'm sharing it now. Can you see it now?
No. Just click on green share button at the middle of the bottom. Yeah.
Can you see it
Yes, we
now?
can see it now. Yeah.
Oh, sorry
We
about
can
that.
see it. Thank you so
Okay.
much. You can
Okay.
proceed.
So I was talking about the effect of falls on elderly patients, and how and why they need enhanced one-to-one care, especially those ones that are confused because of dementia and because of delirium and thereabouts. So, all right, so this particular presentation is coming up from a practice development in falls prevention as a way of preserving patient safety, of improving patient safety, and also of improving their health outcome at the end of the day. So I'm presenting this as a proposal. You could look into it and try to implement it in your hospital, in your facility, or wherever it is you're working, to see how effective it's going to be. So in my own case, we did what we call a pilot study to see how effective it's going to be. Now, it's focused on enhanced one-to-one care. Why do we call it enhanced? Enhanced because sometimes patients who are confused because they've got dementia, they've got people looking after them, and those ones looking after them are also looking after other patients. For instance, you could see a healthcare assistant who is supporting who is working with a nurse to look after patients, and they've got like 10 patients, 12 patients to look after. So if we've got an enhanced one-to-one healthcare assistant, someone who is trained to look after patients who are confused, to look after patients who have dementia and who are at higher risk of falling, if we've got those people who are trained on how to do so, and they come to the ward and they stay with just the confused patient, I believe that it is going to help. And even research, I had to research about it, that if you implement the multifaceted strategies involved, that is going to help. Now, let's look into the SBAR analysis. So SBAR is about situation, background, assessment, and recommendation. Now, what was the situation? Situation, according to Montero Odeso et al. 2022, they did carry out a research, and they found out that there are high falls rates in the elderly care ward, and this is a significant concern, contributing to substantially increase in healthcare costs. Now, this emphasizes the urgency and importance of implementing effective preventive measures when it comes to falls prevention. Now, what is the background? So research, according to Shekel et al., the research they carried out found out that the effectiveness of dedicated one-to-one care for at-risk patients is really high. So when one-to-one care is brought in place for patients who are at higher risk of falling, it's really effective in preventing falls, because at the end of the day, we are trying to lower the number of falls that takes place in hospitals. However, current practices where healthcare assistants multitask for patients prove less effective in preventing falls. So some healthcare assistants, they find themselves in a position where they need to multitask. They need to look after a patient who is for one-to-one care and also look after several other patients. You could see the call bell going off for them to go and attend to a patient, that they have to leave the patient that they are doing a one-to-one care with to go to attend to the other patients. Now, what this does is that it leads to falls. So the patient who is a one-to-one care is not left alone. There is no one with the patient. So they tend to fall at those times. Or sometimes when the nurse and the healthcare assistant are behind the curtain trying to take care of a patient. So while they're behind that curtain, they've got someone who is trying to come out of bed, who is at a very high risk of falling. So it's really a situation that needs urgent attention. Now, assessments, inpatient falls in the elderly care ward were investigated, and some key things in fall prevention measures were identified as ineffective. So those things include one-to-one care of one-to-one care assistant looking after them and also looking after other patients. So when people were asked why did you have to leave your patient who you were looking after as on a one-to-one basis, they said that their attention was needed somewhere else. So because their attention was needed somewhere else, they had to leave where they were and they had to attend to the patient that needed the other patient that needed their attention. So the recommendation here, even according to the research findings by Heng et al., indicates that potential effectiveness of one-to-one care is there in reducing false incidents. So if staff, not every hospital have it, and most hospitals don't even know about this. So if they could, we understand that there are financial aspects of it where hospitals are considering the money involved in recruiting staff that are just for one-to-one care. But then when you think about the financial costs of falls, when a patient falls, the costs, the healthcare cost is really high. Myself, I work in the NHS, and working in the NHS, we know that there are several costs going into managing a patient who falls. For instance, when a patient falls in the ward, we do several paperwork. Some of them involve you need to get the doctor to see the patient. We involve the family, and then if there is a serious incident, the patient may need to go for MRI of the brain to see if there is any bleed going on there. And then they may need their medications reviewing and their blood thinners being withheld because of probably potential bleeding. So there are so when you check the cost involved in preserving a patient, in preventing falls, and then the cost involved in trying to manage a patient who has fallen, you would see that it's going to be a gain to healthcare facilities, not just the NHS, but other private hospitals and thereabouts. So what is the methodology here? If for people who want to implement this, so in our own case, in my own hospital, there was an initial retrospective audit of falls incidents in the elderly care ward. So myself, I'm a falls champion where I work, and I'm really keen about falls prevention because having seen the aftermath of falls, it's something that everyone should be keen about as well, because it doesn't tell good on the hospital. It affects the reputation of the hospital. So we did a retrospective audit of falls incidents in the elderly care ward, and a project team was established. Stakeholders were identified as well, stakeholders involving matron, involving senior members of the team, and everyone involved in looking at our patients as well, and those who are involved in decision making. So a process mapping was completed, and it highlighted the possible impact of enhanced one-to-one care in achieving our aim of falls reduction by drawing insight from the critical social theory. So the critical social theory is talking about how to preserve patient safety and how to enhance their health outcome. Because when we're talking about looking after patients, we are dealing with involving the best level of care with best practices, with evidence-based care. So bringing all of this together, we are looking at the possible impact of enhanced one-to-one care in reducing falls prevention amongst our patients. Then we also involved the PDSA module. It's about plan, it's about do, study, and act. So we know that before you can be able to start rolling out a particular, let's say a particular strategy, like this one is a strategy for falls prevention, you need to test what you're doing. So potential changes to be made includes this PDSA cycle, which involves planning and doing and studying it and seeing if it's going to be effective. Because before it can be implemented, it needs to be studied to see if what we are proposing is effective or not. Is this something we can adopt or something we don't need to adopt because there are better options? So regular meetings with the multidisciplinary team was carried out to discuss patients at risk of falls and impact of personalized one-to-one care. So we had meetings with our doctors, meeting with our physiotherapists, occupational therapists, and these are all the people who are involved in patient care. And the multidisciplinary checklist highlighting the situation of the patients at risk of falls and when prompt one-to-one care needs to be introduced. So we have multidisciplinary checklists as well, and we highlighted what the situation was. And education and training of healthcare assistants recruited for enhanced one-to-one care. So this was carried out, and then I'm happy to say that it's something that we are still doing, because when we did it, we found how effective it was. We compared the number of falls we had when there was no one-to-one care, when it was just the general nurse and the healthcare assistant looking after 10 patients. We compared it with when we had enhanced one-to-one care staff coming to sit with the patient. This doesn't mean they sit with the patient all day. So we shuffle them around different other patients. So when a staff comes to stay with a patient, their staff stays for like 2 hours and then goes to stay with another patient to avoid burnout in the process of carrying out the enhanced one-to-one care. So we also looked at the fishbone diagram. So the fishbone diagram involves the environment. So how is the environment like where the patient is? Sometimes the environment contributes to fall. Environment that is cluttered, that is not properly lighted, environment that that is not in an inappropriate way for patients who are confused, it ends up leading to falls. And then what are the equipments that we use in mobilizing patients? What is the process involved? When we're trying to prevent falls, there are several processes like falls, all these, like staff education, trying to educate staff on what to do. Baywatch is involved as well. And we do a line and standing blood pressure and all of those. So this fishbone diagram, it showcases the environment, equipment, people, and processes that are implicated in falls incidents. And we drew this insight from Leo 2015. So with this framework, processes may contribute more to either a prevented fall or a falls incident. So how does this happen? We looked at the aspect that if staff are not properly trained, if patients are not oriented when they or reoriented, because sometimes you orient them and because they're confused, they forget. So they need that reorientation. And then do we learn from incidences? Are there situations where staff can learn from previous incidents? Like when a falls happen, is it being discussed? And then do we find out why the fall happened and try to prevent it from happening again? And then carrying family along, because patients, they've got their relatives, they've got their next of kin, we carry them along. Sometimes we even ask them to come in, especially when the patient is confused. And they are calm when they are with their own person. So we invite their family to come and stay. So these are all part of the processes that can help to prevent falls. Now, the force field analysis. So looking at the force field analysis, we leverage driving forces to strengthen our fall prevention initiative while actively addressing and mitigating the impact of restraining factors. So there are some factors that are involved when it comes to some restraining factors and factors that can make that are driving factors when it comes to preventing falls. So some of those driving factors are staff engagement, supportive leadership, improved patient outcome, while the restraining ones are staff resistance. Now, what is staff resistance? Resistance is a situation where people are not open to change. So, you're trying to introduce and enhance one-to-one care is something that they're not used to. So they tend to resist it. So another thing we need to look into is how to engage staff, how to motivate them to be involved in a change we are trying to introduce, because not everyone will accept what you're trying to implement in the first place. They want to see reasons why. So we need to be convinced. Probably when they see the outcome, they can get happy and get involved. And then the resource limitation. So I mentioned resource earlier. So sometimes there are financial barriers to you trying to implement a change that is going to be effective. But then we are trying to also look into health economics. We're trying to do to make it balanced to ensure that we're not losing money in the aspect. So that's why this pilot study or PDSA cycle is very important to make sure that it is really effective. So in our own situation, we are already implementing enhanced one-to-one care because we looked into the cost involved in trying to manage the fall incidents and the cost involved in bringing staff to do a one-to-one care. So it came out positively that we spend less when we pay staff to do enhanced one-to-one care, while we spend more when we need to try to manage a fall incidents, try to do the MRI scan involved for those who have potential brain bleed, and trying to introduce several other things we do when we're trying to manage falls incidents. Okay. All right, so in summary, this proposal is just about reducing falls in elderly care through enhanced one-to-one care. It's about addressing current inefficiencies with where healthcare assistants manage multiple patients simultaneously. So it's just about focusing on a particular patient and ensuring that the patient is not left alone at any point in time to avoid false incidences that could lead to various complications like brain bleed in serious cases and then even death. So by implementing this plan, do, study, act cycle and involving stakeholders as well, the aim here is to improve patient safety and outcomes through comprehensive preventive measures. So that is it. So now it's not left for you to take this information back to your facility or your healthcare institution to try and see how to prevent false incidences by managing patients who have got dementia and are confused, or those who got delirium and they are wondering and they are very at risk of fall. Could we have an enhanced one-to-one healthcare assistant that can be with this patient at least for 2 hours, then while another person comes to take over? So it's something that really needs to be put into place to ensure that patient safety is promoted as much as possible. Thank you so much. Thank you so much for listening to me. Thank you, and I really do appreciate being here. Thank you.
Thank you so much for your nice presentation, Miss Sandra. And I would like to open the stage for questions. Is there any questions from the audience? I would like to thank you once again, Miss Sandra. Thank you for the nice presentation. And we'll move forward with our next speaker, Mr. Charles Hale from USA. I am passing him the stage to deliver the speech on securing patient data, healthcare in the age of cybersecurity. Welcome, Mr. Charles. You can
Thank
introduce
you.
yourself and you can proceed with your presentation. Thank you so much
Thank
for
you so
joining
much. Are you
us.
able to see and hear me okay?
Yeah, I can hear you and I can see you.
All right, well, let me share
You
my
can introduce
presentation.
yourself and then you can share your presentation.
Absolutely. So good afternoon, everyone, and thank you for this opportunity to present here today. My name is Charles Hale. I am the president and founder of Hale Consulting Solutions, and we're a boutique consulting firm here in the United States that deals with project management, cybersecurity, and regulatory compliance. And what I want to talk about today is a little bit about securing your patient data and, healthcare in the age of cybersecurity. So let's talk a little bit about healthcare data security and what our environment is like right now. I've worked with some small organizations, with some big organizations, and no matter how much you try, there's no such thing as 100% secure. So that's just a reality of the world we live in. Knowing that, we want to give our very best efforts to secure our environment based upon the needs and risks that we see. Just a few metrics here. As of last year, 2023, the average cost of a healthcare breach is now up over $10 million. And in 2021, over 17% of all breaches occurred in the healthcare industry. The reasoning behind this, the healthcare industry is a prime target for cyber criminals because we have really valuable information. We've got financial information, we've got medical information, we've got personally identifiable information. This is a gold mine for cyber criminals. Combined with a lot of us are using some archaic systems that have been around for a long time and may not be as secure as we would like. And therefore, it is reasonable to expect that we are highly targeted by cyber criminals in this industry. Talking a little bit about cybersecurity and kind of definitions behind it, we really break cybersecurity up into two areas: privacy versus security. Privacy is all about the patients, that the patients feel comfortable that their data is being used in a reasonable and effective manner, that people are using it for patient care and not for advertising, not for other things that they may or may not want to use for, and that their data is being kept. Only the people that they want to see their data have access to their data, their doctors, their health plans, family members that they designate. So this is very specific to the patient rights and the patient needs around their data. On top of that, we've got security, and security is in part about, it adds on to privacy. So we typically talk about three aspects of security: confidentiality, which is exactly what we're talking about here, that only the people who need access to the data have access to the data. The second level is integrity, and that's making sure the data is not being changed by anybody other than people who have a right and a need to change that data. So this is a very critical aspect that doesn't get talked about. The third aspect of security that we hardly ever talk about, but it's critically important, is accessibility. Are the systems up? Is the data accessible to the people who need it? When we talk about ransomware attacks, which is a huge deal worldwide, ransomware attacks are accessibility attacks. So they steal the data, so it is confidentiality, but it's also the main impact that we see is the accessibility, being able to get into the EHR, being able to get into your MRI systems, being able to have access to the data you need to provide healthcare. So there's a critical aspect of security. On top of that, we tend to talk in cybersecurity a lot about laptops and servers, or PCs and servers. But we live in a world of the Internet of Things. Anything that is connected to the internet is potentially hackable. And we're seeing a lot more of that, where people are hacking into surveillance systems, closed circuit camera systems. They're hacking into medical devices. Just recently, my mother had a pacemaker installed. The pacemaker has a Bluetooth connection. It's connected through the internet to the doctor, so the doctor can monitor her health care and make adjustments. And that's awesome, but you want to make sure it's secure. So when you're thinking about security, you have to think outside of just servers and PCs to the broader Internet of Things that are available out there. The threat landscape right now, it really hasn't changed. We've seen some fluctuation between these four items. But the top threat we see in the healthcare industry is still phishing. We also have phishing and smishing, which is the voicemail and SMS texting version of phishing. It's all the same thing. It's sending messages, scam messages, trying to get people to divulge information. Maybe trying to get them to divulge their user ID and password. Maybe trying to get them to divulge, patient information. We saw this on the decline. There's been a lot of educational efforts and a lot of work put into identifying phishing emails and educating people how to identify phishing emails. And we were getting better at it. Then AI came along, and this upped the game by an order of magnitude. We're now seeing much more directed, much better, much more complicated phishing campaigns out there. The cyber criminals are able to, directly target, people based upon their public information. So, I might get an email saying, hey, Charles, great presentation at that conference. We would like to give you this money to reimburse you. Here, click here to collect your money and put your account information in it. It sounds awesome. It's probably a phishing attack. So you have to be very careful in these days. The second threat that we see significantly in this industry is insecure access. And this is really just building the access to your systems in a secure manner, that you have complex password requirements, that the passwords are changed on a regular basis, and that you have multi-factor authentication. The third one, multi-factor authentication, that is a big one. In this day and age, passwords are getting easier and easier to crack, to force to acquire one way or another. There are entire databases of passwords out there available to the cyber criminals now. So we highly encourage multi-factor authentication. It's a little bit of a pain in the butt. We know that. You have to pick up your phone and dial another code, but it increases your security by, like I said, an order of magnitude, and we highly recommend it. The third item we see within the threat landscape are vulnerabilities in the software itself. So these are vulnerabilities in your applications, vulnerabilities in your operating systems, and they illustrate the critical importance of keeping your software up to date. So installing your patches from Microsoft or from Apple, or whoever you happen to be using as your provider. Installing your applications and staying current on your versions of your software you might be using within your system. This is an ever increasing area of activity. We've seen the cyber criminals have, once again, their level of maturity has increased to the point where they are now able to, they get the patch notes and they're able to say, oh, they're patching a vulnerability. And then they're able to reverse and develop an attack against that vulnerability. And we're seeing them do it in very short periods of time. Sometimes on the order of a few days, up to 5 business days seems to be the average. It takes them to turn a patch into an attack. And so if you patch on a 30-day cycle or a 90-day cycle, that leaves a huge window for people to potentially use those vulnerabilities to get into your system. So this, like I said, is an ever increasing area. And then insider threats, this has been around before there were computers, but this is basic training for your people, and the policies and procedures you have around how you grant and terminate access. We still see a lot of breaches that are associated just with misconduct on the behalf of insiders within the organization. Sometimes it's malicious. Somebody might have a grudge against your organization, or maybe trying to extract data for profit. Sometimes it's very benign. The people have no ill thoughts whatsoever. They just didn't know that, hey, I shouldn't walk away and leave my computer unattended while I'm still logged in, or I shouldn't have sent that email via an insecure email method. So this is really human behavior, and it's something that we really push training and education around to prevent. I mentioned our organization does a lot with compliance. Healthcare is a highly regulated industry across the world. This kind of gives you a little bit of an eye chart. Some of the major regulations across the planet. Here in the United States, we have HIPAA, but just about every organization or every country has its own version of regulations to protect the privacy and use of healthcare data within their country. And it's critically important to stay abreast of what these regulations are and regularly do risk assessments to make sure that you're staying compliant as well as secure. Wanted to take a little break and talk about a real world incident we had a few years ago. This was associated with an organization named Broward Health. They're a large hospital organization here in the Southeast in the United States. And they had a breach. Well, actually, they didn't have a breach. A company they did business with had a breach. This was a third-party provider, actually a billing organization that they do business with, that they had provided access to their systems to. So when this other company got hacked, then that gave the cyber criminals access to Broward Health as well, which illustrates the importance of not only securing your own organization, but doing due diligence to make sure the organizations you're doing business with are also secure. In this case, it was a pretty significant breach. We're talking about 1.3 million patient sensitive information, all kinds of things, driver's license, medical records, things like that. Going back to compliance, Broward Health did get fined because of compliance. Not because they got breached, though. Interestingly enough, they got fined because they didn't notify people that their data had been breached in a timely manner. So they had been breached. They were working with the Justice Department to try and determine the who had breached them and pursuing criminal activities. And so they delayed notifying their patients that their data had been breached. Well, that's good intent, but the regulations don't allow for that. The regulations are very specific that you have to notify people here in the United States if their data has been breached in a timely manner. And so they received a significant fine because of good intentions. $1.5 million. Then we talked about compliance, we talked about security. There's a lot of overlap there, but they are subtly different. So compliance, meeting the regulatory requirements in your country. Regulations move very slowly. It takes years sometimes to get a regulation through Congress or through your regulatory body. And so they tend to be way behind the curve. Whereas security, the security requirements today are significantly different than the security requirements 6 months or a year ago. So you have to negotiate that balancing act of staying compliant, staying aware of your regulations and staying compliant with them. And at the same time, realizing that compliance does not equal security. And so you need to also pay attention to the security best practices, doing your risk assessments, do your training so that you have security top of mind as well as compliance. And vice versa, as we saw with Broward Health, they got hit for a compliance issue that was not a security issue. So you really have to address both sides of this coin. Wanted to talk a little bit about a success story. It's a client we worked with a few years ago. We'll call them Metro Health Systems. That's not their real name. But they are a regional healthcare provider. They see about 500,000 patients annually. So it's a good sized organization. But they had a problem, and their problem was that they were suffering frequent attacks, frequent phishing campaigns, and they had actually had some minor breaches. And the regulatory bodies were coming down on them pretty hard about, hey, you guys are not displaying your due diligence, and we may need to fine you or, put sanctions against your organization. So they started at the beginning. They conducted a risk assessment. Risk assessments are kind of where it all begins, knowing what you have and where your gaps are so you can prioritize them and address them accordingly. Once they had their risk assessment, then they were able to develop a roadmap to compliance. And that demonstrated to their regulatory bodies that we are making reasonable efforts to try and become compliant. Results of this, they saw less successful breach incidents, no more breaches, and they were able, like I said, to address their corrective action plan and say, see, we are making progress towards becoming a fully compliant, fully secure organization. And that got the regulatory bodies to kind of give them some breathing room. And they're in a much better place today than they were when they started. Talking about risk assessments, this that we see on the screen is called the NIST framework. It's a very popular framework here in the United States. And in fact, it's the framework that's mandated by our federal government for government organizations. And it's a fairly simple model. I'll walk through it very quickly. The first element of it is identify. And identify is knowing what you have in your organization. What is your hardware? What does your infrastructure look like? What software are you using? What operating systems? It all starts with knowing what you have. So that's a critical first step in any risk assessment. The next is protect. And so these are all of the items that you implement to protect your systems, whether it's the passwords and the multi-factor authentication that we mentioned before. It may be advanced software for data protection. These kind of encryption, all of these kind of things fall into that protect category. The next category is detect. So this is implementing solutions to be able to detect people that are trying to attack your environment. So this is a ever-growing environment. I hate to use the example of CrowdStrike given what happened last week, but this is where they've made their impact and how they were able to, expand so much across the globe is because they're specialists in this protect area or detect area of being able to see, hey, if somebody's downloading too much of our information. Hey, Charles just logged in from Los Angeles, and then he logged in 5 seconds later from Dubai. Maybe it's not Charles. All of these kind of things fall into that protect or detect category. The next category is respond. So what do you do when you have an incident? So you've got to plan ahead. Incidents happen. There's no way to prevent incidents from happening. So it's very important to know what do we do, and having a policy saying if someone in our organization logs in from 2 different locations in a very short period of time that are far away, we disable their access and we send them an SMS text. These kind of things of how do you respond and having that planned out are critical. And finally, the recover phase. This is your plan execution. This is how you recover. If we have a ransomware attack, here's how we recover from it. If someone gets access to our system, here's how we recover from it. And a big piece of this recover is the communication plan. We talked a little bit about Broward Health, about how their communication plan failed them because it wasn't complete and didn't account for timeliness. You've got to know, if there's an incident, who is going to talk to the media, who is going to talk to the patients, who's going to talk to law enforcement, and what are they going to say? The chaos, this can get really chaotic if you don't have a plan for it, in that you may have multiple people talking to multiple people and communicating different things. And that just can really affect both your recovery and your reputation and the potential for fines. And then finally, over all of this is govern, and this is building that program that governs and manages everything we just talked about, that develops the policies and procedures, that has the risk management plan, and just provides that general level of oversight. I throw this up on the screen not to scare anybody and not to go through and read. This is a list of the vendors and products in the cybersecurity space in 2021. I don't have a current list. I'm sure it's an order of magnitude bigger than this. But the idea here is to show you that there are hundreds, if not now thousands of organizations in the cybersecurity space and vendors. And I've worked with many of these organizations. Many of them are very, very good. So when you're going about choosing a cybersecurity vendor, you need to figure out your own needs first and then find a vendor that fits your needs. Just going out and finding a good vendor, they might be really, really good, but they might not fit your needs. So you want to do that needs assessment, that risk assessment for yourself first before you go out to the industry to find a solution. So we'll talk a little bit about setting up a cybersecurity program within your organization. In step 1, we always recommend you identify who is accountable, who is your security officer, who is your privacy officer. We've seen a lot of success when you have someone who's driving your cybersecurity program within your organization. There's a common saying that cybersecurity is everybody's responsibility. Absolutely true. Cybersecurity needs to be, top of mind, and everybody needs to do their part. But you need one person, one captain steering the ship that can decide what your priorities are and how to implement them. Once you have that individual identified who's responsible, then you want to identify who can help. Nobody knows everything. So that person needs to develop a stakeholder team from across the organization that has understanding of the business. Maybe someone from legal who understands the compliance and the regulatory pieces, someone from IT who understands the technology. So this is really a cross-functional function that falls underneath that. And you may need to bring in external help, some consultants to fill in gaps where you may not have that expertise in-house. In fact, the larger the organization it is, the more help they seem to need from outside, because it just gets an order of magnitude more complicated the bigger you get. Step 3, I know I keep harping on the risk assessment, but you can't fix what you're not aware of. So step 3 is performing a risk assessment, working with your stakeholders, working with your consultants to determine what do you have in your organization and where are your gaps, and prioritizing them, figuring out what are our biggest risks, where should we apply our resources to make it most effective. It's very, very difficult to fix everything at once. So that's why you need that list and you need it prioritized so you know what you're going to start with, what you're going to move on to, and then you can check them off the list accordingly. Speaking of checking off the list accordingly, that's step number 4. How do we fix it? So that's implementing your projects and to address the identified priorities. And these can fall in several different areas. There are the technology upgrades. That's the most common. Hey, we need to implement XYZ software to help prevent incidents or to detect intruders. But there are other aspects of it too. Policies and procedures. So, what we talked about with password changes, things like that. Education and training, that's a biggie. So making sure people are aware of their environment and how to be secure and act secure within your environment. And finally, implementing some ongoing audits and monitoring. So it's a common phrase for project managers. You can't manage what you can't measure. So this is where you need to implement some measurements so that you can manage to them. Step number 5, how'd it go? So this is an extension of those audits and metrics, really developing the KPIs, the key performance indicators, and the metrics to measure your cybersecurity success within your organization, and making sure, once again, that these metrics are cross-functional. You can have your qualitative technical metrics saying, what is our success rate on, detecting intruders, what it is our incident rate, how quickly they're being resolved. These are all technical metrics, but you also want to combine that with your business metrics. And the business metrics really revolve around what is our uptime, what is our processing speed, how are people able to get their jobs done? What do their results look like? Audits and testing, we were talked about. The other piece we wanted to talk about is stakeholder feedback. And this moves from the qualitative into the quantitative, but is no less important. You want to get a feel from your stakeholders of, hey, we feel like cybersecurity, we feel secure, we don't feel secure, this is impacting our ability to do our work, it's not impacting our ability to do our work. These kind of feel-good metrics, and as I said, they're harder to measure, but they're no less important than your organization. And so, surveys or just walking around the floor and asking people how things are going is really, really important. And step 6, of course, what did we learn? The lessons learned. As a project management professional, we're always about continuous improvement. This is an iterative process. You will go through it multiple times as your program evolves, and you want to make sure that you're going back and saying, what did we do well? What did we do not so well? What do we want to do differently the next iteration? The road ahead, what do we see coming up for healthcare when it comes to cybersecurity? Number 1 on the list is, of course, AI. I mean, AI is transforming our world, and healthcare is no less impacted than any other industry. So, we see AI greatly enhancing our cybersecurity profile and the ability to, AI can scan millions of logs, whereas a person couldn't, and identify the individual issue. Like I said, AI can much quicker identify the use case I talked about earlier. Someone logs in from one location and logs in from another location. AI can spot that in milliseconds and implement whatever your procedure is. But on the other side, AI is also enabling our cyber criminals, our adversaries, and they're able to use it to develop more sophisticated attacks, more evolved attacks. So there's an escalation here on both sides with the introduction of AI and generative AI into our environments. Number 2, here in the United States, we're seeing a greater focus on patient consent. So historically, healthcare data was the realm of the healthcare provider and the health insurer. Now patients want to be more involved. They want access to their medical records. They want to be able to make comments and request changes to their medical records. They want to be able to control who else can see their medical records. So this is all falls under the patient consent piece. And we're seeing this It's kind of nascent right now. We're still trying to figure out how to deal with it, but it's definitely something that's growing for the future here in healthcare. The third area is risk-based compliance. So we look at some of our older regulations, and they were pretty prescriptive. You need to have encryption, you need to have multi-factor authentication, things like that. As the environment has evolved, our regulatory bodies now realize that there is no one solution, that everybody has different needs. And so they, what you see a lot here in the regulations in the United States is reasonable, that you are making reasonable efforts based upon your organization and your threats to your organization, which, you know, it is both a positive and a negative. The positive is not everybody has to implement the same solutions, regardless of their size or their needs. The negative is interpreting reasonable can be a bit nebulous. So it used to be you could just say, yes, I have encryption. Yes, I have multi-factor authentication. Yes, I have X, Y, Z. Now it's a bit more subjective. And so that makes it a little bit more difficult from the compliance side. The fourth element is medical data interoperability. This is a growing area here in the United States. And that is being able to share data between organizations, between healthcare providers and health plans in a real-time fashion. We're seeing the opportunity here for patient care is immense. You know, having access to the full medical record, not just what you talked about with the patient, being able to see their full history, their immunization history, everything in one go, regardless of where they went or who they did it with. Clearly, the benefits are immense. That said, the more you share data, the more security concerns there are with it. So the ability to secure this data in a shared environment is a whole new level of complexity that we're still tackling with, honestly, and will continue to be an issue of, you know, maintaining that balance between we want the people who need the data to have the data versus we don't want the people who don't need the data to have the data, and making sure that we maintain those boundaries. And finally, global impact. Healthcare is global. I've had friends that have gone to other countries to have services done. Many of us travel around the world to different locations, and we may need healthcare while we're traveling. So the regulatory environment in the world right now is very much country by country, which makes it very difficult as an organization to negotiate, you know, what are our compliance requirements if we're operating in multiple countries, and also what are our regulatory requirements and what are the methods for securely sharing data across international borders. This is something that definitely is a growing need and has not been well addressed historically. So we see more effort going into dealing with healthcare as a global community going into the future. Want to leave you with a little quote. This is talking about data as the new oil. We've all heard that phrase. And just like any advanced technology, we want to make sure that it's being used for the good of people, not to exploit them or manipulate them. That's really what cybersecurity is all about. Is making sure that data is being used by the right people for the right purposes and isn't available to people who might do something nefarious with it. Once again, my name is Charles Hale. Here's my contact information as well as a QR code you can use to get to my contact site. And I would love to continue this conversation. And I see we've had a few chat messages pop up while I've been doing this. So let me stop sharing and see if we have some questions.
Thank you, Mr. Charles, for very informative presentation from your side related to cybersecurity. And I hope it will be helpful for everyone and how we can secure our data. And I just want to let you know there is a question from Dr. Marba in the chat box. Can you kindly read it and answer her question?
Absolutely. So
Thank you.
Marwa asked that, you know, of course, it's important to maintain a strong cybersecurity system in any type of telehealth care. Do you think it's easy to find a good, famous company to maintain cybersecurity systems if in case we're planning to initiate a virtual care center? Any examples of such companies? So Marla, I have to know a little bit more about the organization and what your needs are to make any kind of recommendations. But I can follow up with you after the call, and we can talk a little bit more about this question. Of course, there are a lot of good, stable, established companies out there that can help with this. And I'd be happy to talk with you about it and see if we can't answer your question. Any other questions out there?
Thank you for answering her question. And there is another question from Dr. Udim. Can you kindly read the chat box, Mr. Charles?
Oh, I don't see that question. Was it sent?
Yeah, just a moment. Yeah, she just posted on
Oh.
chat box.
Yep, now I see it. Dr. Udim said that I understand the importance of security, but what happens when we are international and we have partners across the world? Yeah, the whole global healthcare thing, that is a great question. It's tricky because different countries have different regulations. So you really need to work with your law department or with a consulting group to identify the specific needs. It depends on where the data is being housed, what people are doing with it. That's on the compliance side. On the regulatory side, or on the security side, pretty much the same standards for security apply no matter where in the world you're operating. So the principles we talked about in NIST of having an inventory of your systems and assets, having the proper protection on them, having the proper mechanisms to detect intrusions, and then your response and communications plans, those apply pretty much regardless of what country you're operating in. But the regulatory needs are much more complex because, as we said, different countries have different regulations, and whose regulations apply depend on where the data is being housed and what it's being used for.
Hope Mr. Charles Hales replied your question, Dr. Udim. Okay, nice. So, is there any other questions from any of the participants? No other questions, Mr. Charles. Thank you for joining us and presenting your informative presentation on cybersecurity, which will be very helpful for everyone.
Yep,
See you next time.
absolutely.
Thank you.
Yep, thank you,
Yeah.
and have a great day.
Yeah, you too. Bye-bye. I would like to introduce our chairperson, Dr. Giulia Buglioni, and she will be taking care of the chairperson for rest of the session. Thank you.
Thank you. Good morning, everybody. It's my pleasure to be with all of you today. I gave my presentation yesterday about the leadership management, and for today, I would like to introduce our next poster presenter. That is Miss Margarida Marques from Portugal. Miss Marques?
Yeah, I'm here.
So I'm passing her the stage to deliver the speech on bone density and mandibular cortical width biomarkers as obstructive sleep apnea screening tool, a narrative review. Thank you very much. You can give your presentation.
Okay. Can you see it?
Yes, perfect.
Okay, just let me put in big. Well, so good morning. I would like to thank you for the opportunity to lecture about bone density and mandibular cortical width as biomarkers as obstructive sleep apnea screening and narrative review. First of all, let me introduce myself. I'm from Portugal, this small country and beautiful country with a front view to the Atlantic Ocean. I've finished my dental medicine master's degree last week. And on this work are also two professors, Susana Falardo, who is invited assistant professor of orthodontic and sleep medicine professor 2, and Rita Carvalho, invited assistant professor of orthodontics. In the first photo, you can see me and Professor Susana when I present my thesis, who is the work that I finished my dental medicine master's degree. In the second one, we have Professor Susana with Professor Rita in Salamanca in a congress. Now about my poster. Well, the main goal of my poster was to evaluate another possibility to screening and predict the severity of obstructive sleep apnea. In this particular case, we study about bone density and mandibular cortical width. So, the great question now is how we can evaluate bone density and mandibular cortical width. Well, there are two ways to do it. The first one is by a panoramic dental radiograph, a 2D exam, and the second way can be by a CBCT, in this case, a 3D exam. Well, how we can evaluate the mandibular cortical width using panoramic dental radiographs. It is analyzed by the measurement between the longer edge of the mandibular to the upper margin of the mandibular cortex. In the case of bone density, is evaluated in the region of the mandibular cortical body with an increased resolution of the X-ray region and in the first cervical vertebra. I was talking about bone density, mandibular cortical width, and how to evaluate them. But now the question is, why are they so relevant and important to screening apnea? Well, the answer for bone density is because obstructive sleep apnea is characterized for the recurrent intermittent hypoxia episodes, who has many implications in human metabolism, such as an increase of free radicals and of the oxidative stress that causes an inflammatory process increased, what results in a decrease of bone density. Now about materials and methods. This narrative review was searched in two different medical databases, such as Index Medicus Global and PubMed. In case of Index Medicus Global, the keywords used were apnea and bone density, and in cases of PubMed, we use mandibular cortical width and bone density and apnea. Now about the inclusion and exclusion criteria. About the inclusion criteria, made part studies that use polysomnography, type 1 or type 2 to apnea's diagnosis, made part pediatric and adult patients, and articles with a full text. Were excluded clinical cases reported, patients undergoing orthodontics treatments, patients with DIM and syndromes, and pregnant patients too. As you can see, the studies included in this review are shown on this slide, and all of them defend there is many factors that influence bone mineral density, such as obesity and oxygen saturation index, and they are in agreement with the literature, show that in cases of severe apnea, there is an increase in bone mineral density. Here is other two articles that prove what I said before. Well, it is unanimous that patients with OSA have lower levels of total antioxidant capacities associated with oxidative stress and the decrease of bone formation. Hence, the hypothesis of mandibular cortical width is reduced in these cases. In obstructive sleep apnea, the skeletal maturity had retarded as the serum levels of the biomarkers of bone formation called osteocalcin. What has significant results when the patients are submitted to adenotonsillectomy. Hamada et al. Refers another factor besides those mentioned that is associated with bone mineral density, which is hypertension and the alveolar arterial oxygen pressure difference. With this, and according with literature, bone mineral density and mandibular cortical width can be in the future a method of screening apnea. To conclude my study, the bibliography analyzed in this review shows that there is a correlation in the decrease of skeletal bone density visible on radiographs, as well as the mandibular cortical width is reduced and linked to sleep apnea. However, and because it's a recent topic, there is still not enough scientific evidence to support its use in OSA screening. To finish my presentation, I would like to thank you for your attention. Here is a QR code with all the references that I used in my poster and an email of my professor, Susana Falardo, to ask your questions.
Thank you very much, Ms. Marquet, for your presentation. Is there any question from the audience? Okay. So thank you very much for your speech. Our next speaker is Dr. Yudim Izang from Uganda. Doctor?
Hello, hello.
Okay, perfect. So, good morning. I am passing her the stage to deliver the speech on healing through movement, the indigenous way. Thank you very much for your speech.
Thank you very much for having me. I'm going to get connected now. Let's see, share. Cool. Did that, and then, all right, technology will be kind. I'm Messietta. Good morning, everyone. I hope all is well. I am like a 96-year-old grandma who doesn't know how to use technology, so please bear with me. Feels like that sometimes. Let's see. Share screen, got it. Bueno.
Doctor, if you are unable to share, we will share your screen for you. Okay, perfect. Thank you.
All right, can everyone see that? Can someone give me a heart so I can make sure that y'all are with me, please? Dun. Dun, 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 dun. Thank you. All right. seeing the unmute button on and off the screen. Okay, cool. So I utilize movement in my own personal practice of healing, and therefore I educate others on the benefits of it and how it's helped me. So that's what we're going to talk about today. We'll also talk about how to incorporate into your daily life, and then we're going to get up and stretch and move our bodies because it's really, really early over here in the East Coast. It is 6:53 a.m. and my spirit usually does not move until like 9 a.m. So we're gonna move. All right, next up on the agenda, what is movement therapy? What is dancing? I know everyone sees dancing on TV or they have this perception of what it may look like. And for me, that is a very big part of my healing journey because from the first time I immigrated to the US, I was lost. I was 3 years old. I didn't know where I was. And one of the ways in which I grounded myself or kind of, basically grounded myself is dancing. And so I joined our local association, the Kwai Bohm Association, and I danced. We did weddings and birthdays, and that's really just how we commune with God and ancestors and community. But I stopped for a very, very long time because over time, I thought that America was what I was learning was all about productivity and was all about achievement and what you can do for other people, but not in like a positive way, but like in like a soul-sucking toxic way. And I internalized all of that. And it wasn't until me going back to school around, I don't know when this was, like 2018, and saying that I wanted to be the type of person that was there for my students and for my patients and my clients in a way that no one understood. And I thought that I was a normal individual. I am very normal. There's nothing wrong with me. I'm perfect the way God made me. However, sometimes when you look different or speak different or talk different or move different, people treat you different. And as an empath, I held all of that within my body. And through movement therapy is how I got over that and still get over that every day. So I hope that there's at least one takeaway. If nothing, you didn't learn anything from this presentation, is that Dr. Udom is healing and getting to be a better person through moving and then educating others about how that is beneficial. So next, benefits. It offers so many things, not only for your physical body, your spiritual body, your emotional body, every day, proven in food, your energy to manage your weight. I used to be 100 pounds. All right, mental and emotional benefits. Stress reduction, emotional expression. Moving is how I show up in the world. If I am not moving, I'm asleep. But even then, I'm still moving because my brain is always going constantly. It feels like sometimes I have like 17 people in my brain at the same time. And I say there are those different parts of myself, those different ancestors that have all of these hopes and dreams. And sometimes that can be overwhelming in this very human form. And I move to process. I move to transmute other people's energies around me. And I utilize tools, I didn't have that in here, but like headphones, noise canceling headphones to reduce all of those things. And if I don't have anything, I will move. I will move, whether that's writing in my journal or writing, period, whether it's in my phone, coloring or drawing. I have so many things around me that I've utilized. And moving doesn't have to be just your body, like crocheting too. Like you can channel all of that energy into your creativity, but just move because it makes you feel better. It improves your cognitive function. Like I said, you're just I feel like I'm going to speak to myself. These are my experiences. I don't know about y'all, but when I move, I feel better. I'm better able to show up in this world to any random person that I meet on the street, whether or not they are tired, sleepy, they're grieving. I'm able to meet them where they are more effectively without letting it drain me. And so that's some of the ways movement has helped me. Specifically for menopausal women, it helps with hormonal balance, it helps with bone health, it helps with improvement or sleep improvement. Because I have to move to be whole and grounded, I have to do a lot. And so to people who maybe their nervous system is not wired that way, it may look and feel a lot. But when I move every day, like the sleep I got 4 hours of sleep last night because I forgot that this is Dubai time. And because I have goldfish memory, but I'm working on it. I move so much, I dance my little heart out. And then I went to sleep and I feel like I got 8 hours of sleep. And that is just an example of one of the ways movements can help you. And if you do have trouble sleeping, please do something. And we're gonna do it at the end, but just move. Reduction of hot flashes. My mama, I remember when she started to go through menopause and she started to carry around her fan everywhere that she went. And even me, when I was 300 pounds, I wasn't moving or able to move as much. I noticed that my hormones were all over the place and I would get hot and cold really, really quickly. But exercising, moving, all of those things becomes a little bit more regulated. Your nervous system is like, oh, we kind of used to this now. Like okay, it feels lighter. We carry so much and our body remembers that, and our organs and how we talk and how we show up in the world. And so when we are able to release that and transmute all of that, it boosts our self-esteem, our body image, and that can be beneficial in all parts of our life, but especially during menopause when your body is seemingly betraying you like it did when you were, when I went through puberty and all of these things are happening to you and you have no idea what's happening. Moving is helpful. All right, integration. How do we do all this? If you have never a day in your life moved, let's just say that, whatever that looks and feels like for you, how do we do that? How are some of the ways that I have incorporated moving into my practice? Stretching for 5 to 10 minutes a day will help to wake up your muscles and improve your flexibility. Oh my goodness, yes. Especially for those who sit and work at a desk all day. Standing up every hour on the hour. Like I have a timer, not for this, but for spiritual and ADHD reasons. Every hour that goes off. And when that alarm goes off, I stop and I check my surroundings and I stretch and I take deep breaths. Like, all right, am I still doing what I'm supposed to be doing? Let me see how my body feels to check it out. And you can do that standing, sitting at your desk. Go outside. I love going outside. Outside is my jam. I am a tree person. You are not familiar with the Ibibio and the Anan people. We are animists, and I must. And if the outside is not outside, it's inside. So there's a plant nearby me some way, somehow, in wherever I am. And they move too. And so in being one with each other, I move like the tree. And I try to remember that every day, especially during my wind down times when I start to journal and I process out the day, because I don't want, once again, those energies to get stuck. So stretching, whether it's in the morning, in the evening, or both, or throughout the day, is a wonderful practice to incorporate. Walking.
unless the whole ecosystem support nurses to grow in their learning. So this will also help nurses to earn personal growth when they are feel confident in their knowledge. They will feel empowered, and specialty education can help nurses develop a sense of purpose and personal growth. And career advancement. With the specialty education and knowledge, nurses could advance their career to higher position. There is a lot of job opportunities available for more qualified nurses. And there is significant shortage of suitably qualified nurses. So the challenges in specialty education, I think the most important is practicing nurses often work long and irregular hours, making it difficult to find time for additional education. Balancing work, study, and personal life can be extremely challenging. The solution is flexible learning options, such as online courses and part-time programs, can help nurses manage their time better. Institutions can also offer scheduling, accommodations, or post-study leave to support their staff. So in some of the hospitals and offer 1 day per fortnight for study. And the second most important is cost of education. The cost of specialty nursing education can be prohibitive. Tuition fees, study materials, and lost income during study periods add to the financial burden. And this could be solved by offering a lot of scholarships, grants, and employer-sponsored education programs. And also a lot of financial support for the education, and then maybe loans could be forgiven if the nurses achieved specific qualifications and they could be supported. Another global challenge is basically recognition of their qualifications globally. So different countries have varying standards and recognition criteria for nursing qualifications, which can complicate global mobility and career advancement. So nurses normally move from one country to another country to work, and if their qualifications need to be recognized globally in order for them to practice in different settings. And the solution is to seek programs accredited by internationally recognized bodies, or institutions can be partnership with global nursing organizations to support qualification recognition. The fourth biggest area is many registered nurses have associate degree or diploma level qualification, which is normally 3 years diploma, which leads to registered nurse qualification. And in order to study further on specialization, most of these specialty courses are available in postgraduate level. And in order to get admission to postgraduate level qualifications, many institutions need bachelor's nursing qualification. So this is again another barrier for people to continue specialization education. The solution provided by Institute of Health and Management, our college in Australia, is we have partnership with Ramsay Healthcare, the biggest private hospital network in Australia, to provide employer support to nurses undertaking specialty nursing education. So we collaborate and we understand the hospital requirements, and we also adopt the hospital culture and their policies into the training program. So building the program together and co-curriculum development is done along with the industry partnership. We also partnership with Arizona State University to provide global recognition of curriculum and gain access to world-class learning resources and curriculum for specialty nursing education. Being an Australian provider with a global university supporting, I believe we could provide high quality learning resources and up-to-date resources for specialty nursing education. And we also partner with Sindhana Alliance, which have 22 countries operation, and around the goal is to connect universities globally. So when we talk about nursing qualifications recognition in each country, basically we partner with each of the university partners under the Sindhana Alliance to gain qualification recognition in their country. So by providing this, we are still anticipating that nurses from various countries will be able to practice the same curriculum through the mutual recognition arrangement. And if they move from one country to another, they could continue to gain the recognition. So our current courses, mainly we offer specialty nursing under one course, graduate certificate in advanced nursing with 12 specializations. So most of the specialties in critical shortages, critical care nursing, emergency, I think mental health nursing and palliative care and perioperative nursing in Australia. And there is also midwifery shortage in a very big way. And all our graduate certificate students can proceed to our Master of Nursing program in order to finish their masters. And so we offer the specialization in the graduate certificate level. And this is a part-time 1-year option. And most of the nurses need a lot of support during this time. And this is for practicing nurses. That means their practical component is undertaken as they as they're working in the industry. So the postgraduate diploma of advanced nursing course, this is a program which we are actually working with other country partners in order to provide opportunity for global nurses to join our program, which includes a direct entry for GNM and associate degree qualification nurses, because they can directly go into a postgraduate specialization without going through bachelor of nursing qualification. But they need to have some experience in the specialty where they want to study. So we encourage nurses to continue education with their employer support in the country of practice and provide advanced nursing care to the patients. I look forward to partnering with employers, universities, and health services to provide world-class care to everyone globally. So in Australia, as we show in the screen, we are partnering with Sindana and Arizona State University. And we are also partnering with the more healthcare organizations like Ramsay Healthcare in order to provide contextualized program for their hospital needs and specialty requirements. Once IHM's graduate certificate in advanced nursing specialty course is approved in the UAE, I believe the nurses will continue to working and serving the community there. We are committed to building advanced nursing practices globally. Thank you. I'm happy to take up any questions if any.
Thank you for your presentation. Is there any question from the audience? Come on, don't be so shy. Okay, so thank you very much, Doctor, for your presentation.
Yes, thank you.
Our next poster presenter is Miss Paola Granda from United States. So I am passing her the stage to deliver the speech on pathways to obtaining a dental license in the United States.
Thank you.
Thank you.
Okay, so I'm gonna be presenting the pathways to become a dentist in the United States. My name is Paola Granda. I'm a doctor and dentist. I'm from Ecuador, and I'm currently working in the United States. This is a very general, comprehensive guide. The process is more complex that I'm gonna show you, but I'm just gonna touch bases on the very important parts. So I'm gonna go over for requirements, credentials, DentSpin, IMBDE, TOEFL test, ADIA CAPATE, ADIA PASS, state license, and networking. So the very first that you have to do is graduate from dental school, right? You have to collect all your dental degrees. Yes? Okay. Dental degree, research projects, shadowings, awards, everything that you have built as experience in your dental school, collect those, because that's gonna be so helpful for you when you're gonna put on your CV or resume. Also, you have to have activities non-dental related, such as volunteer, sports, hobbies, because schools want to know that you have a life outside of dental school, right? And you have to balance those. So step 2, you have to create an account for DentSpin and ECE or WES. These two are the same. So the DentSpin, it's gonna be basically like your social security for dental schools. This is a 8-number identification that helps you protect your personal identifier. And the ECE is the Educational Credential Evaluators, which here you have to send them your original documents from dental school, and then they'll send you back when they're ready. This is just a translation from your education system to the US or Canadian system. And I let them the links below if you want to go to those websites. So then you have to prepare for your dental boards. Keep in mind that all students here in the United States, they have to pass these dental boards. So if you want to become a dental here, you have to pass this dental board as well. So the study resources you can have on a computer or books. I really like the computer because it's very interactive, the way that they study, because you can simulate the exam. It's not the same questions and answers for the exam, obviously, but it's the same study materials. But if you like to study for more like dental decks, you can do it. This is the flashcards that they have, or the books. The time frame that you have to have for the study, it depends all on you. It can take you 6 months to a year. It's all up to you. Then you have to take the TOEFL test. If the ones that have already passed this exam, you know it has 4 sections. Is the listening, speaking, writing, and reading. So the target score is gonna be 90 or higher than 100. Okay, so this is the ADIA CAPIT. This is the centralized application for advanced placement for international dentists. It simplifies the application process by allowing you to apply to multiple programs to one application. It's available to foreign educated dental graduates who wish to practice dentists in the US or Canada. It has 4 sections: personal information, academic history, supporting information, and program materials. Once you have all these ready, you can submit your application to every school that you wish. On ADIA CAPIT is only for advanced standing programs, which it means you have to go back as a pre-dental school 2 years. But if you don't want to go back to school as a pre-dental, you can also apply to ADIA PASS, which is a postdoctoral application support service. It has the same process, but this you're just gonna apply for your postgraduate. And at the end, you're gonna take the dental license test, which is the final step, basically, after 2 years or 3, whatever it takes for you. And it has a part, it's written or computerized with a mannequin or patient, and it depends on the state. The exam is called REP, CDCA, or another one. You have to keep in mind that on Delaware State administers its own patient exam, and New York requires completion of approved postgraduate. So that means after you graduate, you have to do 1 more year for residency program. And that was it. Do you have any questions?
Any question from the audience? Anyone? You can also share your questions on the chat if you prefer. No. So thank you, Ms. Granda, for your presentation. And I don't know who is our next speaker, but okay. So our next speaker is Dr. Noah Letton from Grenada.
Okay, thank you so much.
Okay.
You hear me?
So I am passing him the stage to deliver the speech on senescence exclusion syndrome, appraising the efficacy of current interventions. Thank you.
Okay, wonderful. Do you see my screen? See my shared screen?
Yes, perfect. Thank you.
Okay, wonderful. Thank you so much for having me. What have I just done? Okay. Thank you so much for having me. It's indeed a pleasure speaking here today. Forgive my voice. I'm a little bit under the weather, but I'm here today to talk about senescence seclusion syndrome. It's all about talking about the isolation elderly people go through and all of that. It's about the extended social isolation in the elderly. We're going to be looking at the treatment and the interventions and looking at the efficacy of the current interventions. This is my disclosure statement. And of course, this is the outline. We're going to be looking at the background, study objectives, methods, findings, policy implications, practical recommendations, conclusions, and of course, references. Now, looking at the background, all of this whole study came from an experience I had with a colleague several years ago. And she said that she wouldn't want to get old, she wouldn't want to get old and all of that. And I was wondering, I thought a lot of people would like to get old. And she said she wouldn't want to get old because she wouldn't want to be a burden to society. She wouldn't want to be a burden to family and all of that. But most importantly, she wouldn't want to be lonely and all of that. So I thought about that for several years, and it gave me it kind of led the way for me to do this study. And I came to realize that a lot of old people are indeed lonely and all of that. So I came up with this study, senescence seclusion syndrome. As you can see here, it is characterized by prolonged social isolation. And we can see because the elderly population is increasing, this senescence seclusion syndrome is also increasing. This syndrome has public health implications. It can also impact mental health, physical health. It can also impact social well-being. And it is important that we note this syndrome when we find them, we note them and we tackle them. Also, not just tackling them, but to prevent them, to stop them from happening, to nip the bud. And of course, we have several interventions to do this. And these are broadly categorized into social, technological, psychological, and of course, physical. Once again, I apologize for my voice. I really apologize for my voice. The study objectives are to assess the effectiveness of interventions, to analyze the long-term impacts of interventions, to guide future research, and of course, to inform policy and practice. Now, what methods were used here? Basically, we searched databases like PubMed, Scopus, and Google Scholar. And of course, we included studies that had to do with intervention. There were interventional studies that were carried out between 2019 and 2024. Of course, after all of that, we came up with 40 studies. So this whole review involved going through 40 studies, comprehensively reviewing 40 interventional studies. So what do we find? Our findings are going to kind of be thematic into the interventions. What do we find? As regards the social interventions, we found that interventions that promote consistent social engagement, such as community-organized social events and structured group activities, all of these significantly reduce loneliness and bolster social connections. Also, things like volunteering programs also can help individuals of this age kind of minimize this senescence seclusion syndrome. We also found that creative and cultural activities like singing and dancing, one of our previous presenters talked about dancing. Dancing is indeed a healer. We found that when they engage in this kind of cultural activities, it kind of improves their well-being and, of course, reduces the loneliness they go through. But we have key factors that kind of contribute to the effectiveness of this social interventions. And these include regular structured interactions. Okay, they have to be regular and structured. It has to have some cultural relevance, as in it has to go well with the culture of the individual. It must be meaningful, and there has to be support networks. Also, we found that there are some things that needed to be done when talking about the social interventions. And of course, in this area, further research is needed. This includes things like a long-term impact. What is the long-term impact of the social interventions? What about the scalability? What about in diverse populations? If you're dealing with diverse populations at the same time, how do you go about it? So I think further research will look at these points and try to address them. What about the technological interventions? All of this have to do with things like artificial intelligence, AI, and virtual reality. We have things like digital platforms. We have things like online platforms, like the social media platforms and all of that. We have things like telehealth and tele-delivered interventions and all of that. All of this notably enhanced elderly connectivity with their communities. Factors that contribute to the success include accessibility and usability, engaging content. It has to be engaging. They have to enjoy it. Personalization, it has to be tailored to the particular needs of the individual. There has to be support. And of course, because it is AI or technology, there also has to be training. Certainly more research is needed on digital literacy. Long-term impact is also a recurring factor here. Equity and accessibility is also what looking into further, and of course, integration with other interventions. We now look at the psychological interventions, and this psychological interventions such as CBT, cognitive behavioral therapy. We have things like psychotherapeutic interventions. We have other things like resilience and wisdom focused interventions. All of this has been shown to be effective in alleviating symptoms of anxiety and depression associated with the syndrome. Now, how do we make this successful? The approaches need to be structured. We can do these sessions in group settings. We found that group settings really help these individuals not just tackling the syndrome, but it also helps them to interact and to socialize with other people. We also have to do this in some sort of remote way. How can we reach these people without seeing them directly? In that case, we have things like telehealth. We can combine the telehealth, which is part of the technological, with CBT. We can combine both of them, and the effectiveness is really, really profound. And of course, we have to focus on resilience and enhance effectiveness. The long-term impact, once again, is something that needs to be looked into as regards the psychological interventions. We also need to look at diverse populations and how this psychological interventions, how they go with other interventions, how can we combine them, how can we bring the best out of them. All this need to be looked at in future studies. Finally, we have the physical interventions, and all of this have to do with things like exercise and all of that, and other activities that are fostered exercises. And we have other activities like community-based programs, like community-based exercise programs. We also have structured exercise programs. All of this have fostered improvements in the physical, mental, and social well-being of the elderly. Now, making this successful, there has to be also group participation. Group participation in these interventions is very effective because, as I said, it enhances their interactions with other people. So group participation is one of the factors that is necessary for success, structured programs, and of course, combination with social support. We also need to look at remote accessibility. All of this can basically improve the success rate. Once again, the long-term impact, this is a recurring decimal. So we really need to look at the long-term impact of this intervention. We also need to look at diverse populations. How do diverse populations take this exercise? How can you engage these physical interventions in the presence of diverse populations? What's the best way to do it? We have to look at how these interventions go with other interventions. Can we combine physical? Can we combine with social? Can we combine with technological and all of that? All of this need to be explored in future studies. So looking at all of those findings, we have some policy implications for the policymakers. What must be done? There should be some sort of integration of multi-dimensional interventions. We should have policies that try to strengthen a holistic approach, which kind of combines all the interventions, be it social, technological, psychological, and physical. We need to kind of strengthen a holistic approach that combines all of this. And not just strengthening that, we need government's commitment. We need resource allocation. All of this are necessary to sustain this multi-dimensional interventions. What else can we do policy-wise? We can look at accessibility and equity. Government should invest in bridging the digital divide. It's obvious that we have a lot of a large divide when it comes to digital awareness and all of that. So government should aim to bridge this digital divide and come up with policies that guarantee that interventions are accessible to all older adults. Now, not just the patients or the individuals, but also the caregivers and the professionals need to be included in the policies. Policies should mandate comprehensive training programs to ensure the effective implementation and management of interventions. So having looked at the policy implications, we're now looking at the practical recommendations. What can be done practically? Now, we should look at the community and group-based programs. In this case, we should organize regular and structured community activities that are tailored to meet the cultural and linguistic needs of diverse populations. We should also leverage technology. In this case, we can develop and promote user-friendly platforms that facilitate social interaction and mental health support, and offer digital literacy training programs to help adults become comfortable with using technology. We can also look at the psychological interventions and implement both group and individual psychological sessions and expand access to telehealth. Telehealth is one very important way we can deliver psychological interventions. We can expand access to telehealth services to reach homebound older adults and those in remote areas. We can also have a look at the physical activity programs. And in this case, we can create exercise programs suited to the physical abilities of older adults and integrate social components into these programs to foster social engagement. We can also look at support and training, once again, for caregivers. In this case, we should develop comprehensive educational programs for caregivers and implement respite care services to provide caregivers with necessary breaks, helping to prevent burnout. So in other words, the caregivers also need care. But finally, and of course, not the least in all of this point, is monitoring and evaluation. There has to be some sort of regular assessments to monitor the effectiveness of interventions and establish feedback mechanisms to gather input from participants and caregivers. Having said that, to conclude, each type of intervention to have their own unique strengths in addressing SSS. SSS is senescence seclusion syndrome. Combining interventions can create a holistic strategy to combat isolation and improve the overall well-being of older adults. Continued research, as we said, policy support and practical implementation of these interventions are necessary to creating inclusive and supportive communities for the aging population. And having said that, that is all I have to present today. Thank you so much.
Thank you, Doctor, for your presentation. Is there any question? Okay, so thank you very much for your presentation, Dr. Noah. So our next speaker is Dr. Kirti Moholkar from UK. Okay. So I'm passing him the stage to deliver the speech on designing your dream career, preventing burnout, and finding your destiny. Thank you.
Great. Thank you very much. I hope you can see my slide and you can hear me as well.
Yes.
Okay, brilliant. Yeah, so thank you very much for letting me present at this conference. I think it's been pretty insightful and I've loved the part that I've watched. My name is Kirti Moholkar. I'm a knee and shoulder surgeon. I work in the UK. And I also have founded and I'm a chief executive of my institute called Fulfilled Careers Institute, through which I'm doing the work on burnout prevention and letting people find their fulfillment, if you like. So what am I going to cover today? I'm going to talk briefly about careers and then healthcare in specific. We'll talk about statistics, burnout in brief, the causes, the solutions available, and then how I've been able to craft my my fulfillment program. So a bit of pretext. My talk, I would have really loved to be there and present. I've been in Dubai several times. It's my home, and I'll tell you the reason why shortly. But there was a time when I thought I will be there. We always have a tendency to take life for granted, don't we? But unfortunately, about 2.5, 3 weeks ago, I lost my dad, and it just basically completely changed my my timetable, and I had to travel to India and so on and so forth. But that's basically the reason why I'm kind of doing this this online. Otherwise, I would have really preferred to be there and do the talk in person. So careers, what is a career? The Oxford Dictionary defines career as a long-term professional journey involving a sequence of jobs or roles in a particular field or industry marked by progression and personal development. There was a study in the US which asked bystanders about why do they work, and the questions were answered in a very random, candid way from people who were slightly confused to, oh, I don't know why I work, or because I don't know what else to do, to some clued up individuals saying I work for meaning, I work for passion, or it is for my purpose. And some were very plain and straightforward, suggesting they work because they need to pay bills. And that's not wrong. Why do people work in healthcare? Well, there are some who say, well, my parents pushed me into it. Some say healthcare is fairly respected. It's a glamorous and sustainable environment. It pays well. But is it all rosy in healthcare? No, I don't think so. Let's compare the statistics. If you look at stress, 60% of non-healthcare workers are stressed. This is slightly higher than the 40% odd healthcare individuals being stressed. The non-healthcare is basically because of job sustainability, low pay, and so on. With regards to burnout, the non-healthcare usually have about 23. If you look at burnout in healthcare individuals, particularly the study that I've quoted down below, the numbers rise from 40 to about 87%. That's a very, very high high percentage. On day one, it was Dr. Priyanka who presented the UAE burnout rate of 51%. That's half the population. That's not good. We need to do something about it. Depression in non-healthcare is 7%, whereas in healthcare, 25%. How many people leave the jobs? 43 in non-healthcare to 17% in healthcare. So we guys in healthcare are resilient. Even if you're happy, we stick by. Is that right? Is it good? I don't know. How many individuals leave the face of this earth, take their own lives? 14% in non-healthcare. It's double in healthcare, 28%. If you look at the American statistic, one doctor a day is losing his or her life. That's because of suicide. That's the American burnout rate. So the careers in a person who's a very happy individual with his job satisfaction and so on would have good days that turn out into weeks, months, years, and lives. But the people who are unhappy, their good days defined as nothing bad happened today. As soon as erosion of engagement with job happens, burnout begins. Individuals start calling off sick, substance abuse, alcohol, smoking, binge eating. Some leave the jobs, personal grounds, divorce, complications, errors, and deaths at the hospital. So what is burnout? Burnout is a state of physical, emotional, and mental exhaustion, often caused by prolonged stress or excessive work demands. And there are plenty of studies now available. One of this talking about burnout among physicians ranging in different specialties, the lowest being in public health to the highest, about 65% in emergency medicine. That's staggeringly high. The personal impact on the healthcare heroes, physical health, mental health, they're dissatisfied with their jobs, relationships, and some commit suicide. There is a study available on suicidal ideation in the Nursing Journal. There's impact on the society with regards to economic as well as public health issues. Impact on individual hospitals. Staff leave jobs. There is cost to replace them, complications, litigation, and reputational damage. There is gender disparity as well. So what are the causes of burnout? Now, they can be broadly classified into institutional reasons and personal reasons. The institutional reasons range from lack of appropriate training to lack of focus to high expectations, demand and resource imbalance. And there are the personal ones, which are between behavior of the individual, resilience, the culture, and personality. So if you talk about the job and personality fit, which is where I've done most of my work, if you fit a person into a wrong job, it's like sticking a square cube into a round hole. When the square peg is forced through the round hole, the edges are damaged. Now, that is a similar analogy or metaphor for individuals who are placed in a situation that do not suit their skills, personality, interest, or capacities. It leads to psychological, physical, and ultimately generalized strain causing burnout. A person who is unable to fit in the job is a bruised, frustrated, and an unhappy individual. I remember of this lady who is a daughter of a friend of course, I've disguised the identity. This is a lady who was told by her family that she has to be a doctor. She was not happy. She had to go there anyway because it was the dad's wish. She went into the medical school. She was there for about 3 months. She left the medical college. About 6 months, nobody knew where she was. She returned home. The dad forcefully asked her to go back into the medical college. She was there. She did listen to him. She was there for about 6 months. She's not to be found. Nobody knows where she is. Job, person conflict. There's lots of literature about personality traits and the relationship of that to jobs. And my work started around personalities way back, but I founded the personality institute called Fulfilled Careers Institute in 2019, and my work increased. And there are loads of papers and literature available about how burnout can be related to personality. Now, let's compare what I'm talking about. So if you look at the picture on your left-hand side, this one, this individual, the middle one, is a happy, friendly person. The second one is a dominating, task-oriented person. This is an analytical and a methodical person, whereas the right one is a careful and law-abiding person. Nobody is wrong. Nobody is right. This is just how they work. This is how their style is. This is how their personality is. They have come to the face of this earth based on their own reasons, their own calling, or potentially nobody knows, but that's how they are. That's how they work. Imagine that this happy-go-lucky person fuels with his friends, with his environment. He's very, very happy in that environment. Imagine this alpha male who basically likes to dominate, run around well, task-oriented. He does his job quite well, but that is what fuels him. You look at this individual, he is a law-abiding person. He's looking at his speedometer. He's looking at the traffic. He is very happy in his own skin. Look at this individual. He's worried about things. He's worried about things, but he's not doing any harm to anybody else. This is what these guys are happy with. As soon as you get a Ferrari-driving, capitalistic, millionaire aspiring person to become a doctor, that's a misfit. You get an analytical, argumentative person as a nurse, they may not thrive. You get that dashing alpha male as your secretary, you know what will happen. A softy, docile manager will never manage. And if a doctor was a salesperson, he or she will virtually feel like how that picture is depicting. So an accidental healthcare worker, the people who are very, very happy, they remain happy, they'll die happy, and they have a truly fulfilled career. There is a certain group who are superficially happy, but they remain happy for about 7 to 10 years, and then later on they get stressed out. They die with unfulfilled dreams. They need help. And literature says that even if they were to change about 20% of their work in a meaningful way, this will reduce burnout. And there are these unhappy workers who are coping somehow. They are coping. They are leading an unhappy life. And they remain unhappy because they are indecisive. They don't have any knowledge about the way in which they can change the system, or there is no system, or they don't have desire to change. So there are multiple strategies available to prevent burnout. To recognize it first is the most important. There are institutional measures, which I'm sure the institutions are doing for their healthcare workers. And there are individual measures. There are community measures in treatment. And for this purpose of the talk, I'm only dealing with individual measures. Now, very commonly in a hospital environment, if you don't look at individual needs, you shove it down their throats about wellness programs, mental health support, meditation, mindfulness, take holidays, take time off work. These are guys, we don't know exactly what they want, and they are unhappy. Imagine if you were to get this happy-go-lucky person who wants to be among his friends. You get him isolated into a classroom course. Is he going to be happy? You get this alpha male to meditate. You get this law-abiding person to say, speed up, I want to increase efficiency. You get this guy on positivity lessons. He's not going to be happy. So we need to be looking at what we need, what the individuals need. Now, I'll tell you, as I said, I'm a very happy surgeon, and I've been there for the past about 20 years. I'm not bragging, but I'm known for good results of my knee replacements, and that's basically because of my perfectionist attitude, and I love my patient outcomes. I am absolutely happy doing that. I've had comments from patients And I'm sure the surgeons and the doctors in this particular group would be able to relate with me. There are individuals who come in and say, thank you very much, you changed my life. And I wanted to remain a knee surgeon for the rest of my life until on a cold, chilly evening in the UK, I had a phone call. From my nephew in India. He said, Uncle, Dad has collapsed. Dad is his dad. He was my younger brother. He was 50. I stayed with him on the telephone call in Birmingham while he was in India, 25 minutes, while he was being rushed by an ambulance to the hospital. And the doctor who was examining him kind of broke the bad news. And he said, no, your brother is no more. He was 50. He was just 50. That absolutely changed my life. That changed my life and my calling from being a knee surgeon to being somebody who can help people help their careers basically started. This is my second passion, if you like. My first passion stays as a knee and a shoulder surgeon. I don't intend on leaving it, but I've taken my career fulfillment help gain to the next level. My brother had some unfulfilled dream, wouldn't he? He went at 50. And I decided that I will continue helping individuals. And I've had this experience for about 15 to 18 years of my life prior to my brother's passing. And now I'm taking this work even further. I had formed my institute in 2019. The burnout work was continuing. I wrote my first book on burnout prevention and finding fulfillment. It basically in 24 hours turned out to be a Amazon bestseller. I continued with my career fulfillment program. My second book is on its way. That's my first book called Prevent Burnout and Find Fulfillment. If anybody wants a copy of that, the QR code will take you to the Amazon site. This is my next book called Claim and Caress Your Careers. This book will come out within about 2 weeks because of my 3-week dad passing away event. This launch has been delayed, but I suspect another month or 6 weeks and it should be out. There is quite a bit of agreement amongst the clinicians as well as doctors as well as healthcare community about the relationship of personality to burnout. And there are times when you could be a student, you may be just starting your career, you could be in the middle of your career, you could be about the pinnacle of your career, or you are about retirement. There are multiple choices available. As somebody says, your life is a result of choice you make. If you don't like your life, it is time to start making better choices. It could be your first career. You may have a friend, a son, a daughter, a nephew, or whoever that is confused in trying to choose their career. Or you could be in the middle of your career and you're not happy. If you're happy, fantastic. Help others. But if you're unhappy, take a decision. Who is the Dream Destiny for? Dream Destiny is the name of my program for new aspiring professionals, overwhelmed individuals who are in the middle of their careers. I help individuals, I help nearly burnt out groups or companies or hospitals where productivity has paused and the team is not able to carry on with their work because either there is too much of confusion, too much of fighting, too much of conflict, too much of fitting the square people in round hole job type of environment. So the first choice, the first time career, this could be an alpha individual. Now they would be best suited for sales and marketing team roles. The friendly people are very good in healthcare. The number crunching people are good as accountants. Analytical people can be fantastic lawyers. Team workers are good secretaries. Entrepreneurial guys or ladies are good business owners. A Ferrari driving millionaire should be a capitalistic. He shouldn't be a doctor. He's never going to be there. Who can identify that? So I've basically I'm going to skip a couple of slides In fact, let me take this one. If you were in the mid-career level, you could get fulfillment just by reducing some of your hours at work. You could get into a management position. There could be a side gig. You don't necessarily need to make money. As we said, 20% of meaning in your work and you could be fulfilled. You could part pivot. You could completely pivot. You could plan your retirement. Look, life is worth living. Work is important, but work is only a part of life. As they say, only wine and cheese improve with age, retirement or leave. There are multiple studies out there. Now, this was on Boeing employees. If people at 55 retired, they lived until about 83. If they retired at 65, they died in 18 months. This is quite an old study now, and it's been replaced with the new saying being retire early, die early, retire late, die late. So whichever study group you want to belong to, if it was the old one, again, there was one study from the surgeon groups. If the surgeons were to retire at 60, they live up to about 80. If they retire at 68, they die in about 2 years' time. This is all to do with stress levels, and this is all to do with how you lead your life. So retire early, die early, or retire late and die late. It depends upon what you want to do. So briefly about the Dream Destiny plan that I help individuals with. It's a 6-week program that I take individuals through. In the first week, we talk about the baseline, their needs and their strengths and weaknesses. The second week is where we assess their personality and do a detailed, personalized debrief where I sit with them and their either spouse or their parent. The third week is called their why week. This is where we explore the values and their motivators. In the fourth week, we strategize and do a gap analysis. And this is probably the transformational week wherein quite a few people are overwhelmed just basically understanding the reason about why they were where they were. So if somebody was choosing the career for the first time, this is kind of an enlightenment moment. Or if you're in the middle of your career, there are individuals who've said, goodness me, why did I know about this before? The fifth week is an accountability week, and the sixth week is a goal-setting one. So there's a saying called, what is the happiest place on the face of this earth? It is the graveyard where unfulfilled dreams are buried. I usually say dream big. Dream big because dreams are not expensive. It's free. The choices are the ones that will allow you to make it or break it. Conviction and convenience don't live on the same branch. Sometimes going against the flow will lead you to success. I've used this program on colleagues, surgeons, medics, my friends, my family, and my daughter and son. My daughter is an accomplished doctor who's first year interning, fantastically happy with her life. And this is based on her personality and values. My son, who's probably sitting very close to where you guys are, he's working as a real estate agent in Dubai. And he's just making it massively, happily, healthfully, in a fulfilled way. This is my my details if anybody wanted to have a look at. And I think that ends my talk. Thank you very much for your attention.
Thank you very much. So now I would like to ask if there is any question from the audience. So thank you very much, Doctor. Our next speaker is Dr. Sinem Eroglu from Turkey. Okay. So I'm passing her the stage to deliver her second speech on qualitative studies of patient safety in nursing, a bibliometrics analysis. Thank you.
Thank you. Hello again. I had planned to do both of my research face-to-face, but it was not possible for technical reasons. But I am so happy to be here. Thank you for the grateful presentations and program. My name is Sinem Eroğlu. Dr. Şebnem, Dr. Turgay, and I planned this study. I will tell you about our work is that qualitative studies on patient safety in nursing, a bibliometric analysis. Firstly, I will start background of the study, then purpose of the research, then methodology, and I finished results and recommendations. Patient safety is one of the components of quality of care in providing healthcare services. And it's one of the important parameters of providing a qualified and professional service. According to the World Health Organization, 1 in every 10 patients is seriously harmed due to medical errors. When we look at the research and studies on patient safety, it is seen that the foundations were laid in the United States, and that there are many researchers, analyses, and reports on patient safety. So what is bibliometric methodology? Bibliometric analysis is one of the qualitative and quantitative analysis methods used to evaluate the impact of individual researchers, research groups, countries, institutions, or journals. Bibliometric methods can help researchers explore the literature before they start reading and guide the research work by showing the most effective studies. For purpose of the research, the bibliometric analysis method is carried out for performance analysis and science mapping purposes. So this study aims is that to provide an overview of existing research using bibliometric methodology, identify current topics, and highlight emerging trends in the field. Performance analysis and scientific mapping methods were applied in bibliometric methodology. The data were analyzed with VOS-Viewer and bibliometrics software. The data of the research were obtained through Scopus. The search was conducted again on July 15, 2022 to obtain update data. The search strategy was carried out as follows. As a result of the search, 709 articles were found. The inclusion criteria for the search were first one is articles and review studies, and second is that articles in English. So accordingly, 691 articles were included in the analysis. For results and recommendations, first we will see performance analysis. When we look at the characteristic of the publications, a total of 691 publications, including 663 articles and 28 reviewers. The publications were published between 2002 and 2024. The publications were authored by 3,055 authors. There are 1,665 keywords and around 25,000 references in the publications. The graphic shows the change in the annual number of articles from the beginning of the 2000 until 2024. A significant increase trend is observed, especially from the 2010s onwards. These findings show that the issue of patient safety in nursing has attracted more and more attention over the years, and there has been a significant increase in the number of qualitative studies in this field. We can see the highest number of articles and the highest number of citations in this table. Based on this data, the Journal of Clinical Nursing, BMJ Open, and BMC Health Service Research were identified as the journals with the highest number of publications in this field. In terms of the number of citations, the journals with the highest citations are BMJ Quality and Safety, BMJ Open, and BMC Health Services Research. These journals constitute a significant portion of the qualitative studies on patient safety. When we look at the authors with the most publications, Molly, Mojtoba, and Wendy stand out, 7 documents each. Wendy, Sarah, and Molly are the most citations authors respectively. Wendy has 288, Sarah has 228, and Molly has 145 citations. These authors make significant contributions to the scientific literature on patient safety in nursing. When we look at the most productive countries, we see same results for the most citations and the countries that contribute the most studies on patient safety in nursing. These countries are the United States, the United Kingdom, and Australia, respectively. The collaboration of countries with at least 5 publications are presented in this figure. It consists of a total of 26 countries, 10 clusters, and 65 links. The countries with the most collaborations are the United Kingdom, the United States, and Australia. Additionally, the country pairs with the most collaborations are United Kingdom, Australia, Sweden, Norway, and USA, United Kingdom. You can see dark blue countries, it indicates more frequently international collaborations, and the thickness of the red line between 2 countries reflects the magnitude of their collaborations. You can see here. For the scientific mapping, the thematic analysis was conducted based on the author's keywords using VOSWeaver. The keyword threshold for the analysis was set to 10. For thematic analysis, we can see 5 clusters. These are red, green, blue, yellow, and purple cluster. I will explain what they are. We can see thematic analysis results in this graphic. The network consists of a total of 32 keywords, 5 clusters, and 22 links. You can see here. For the red clusters, its topic is qualitative research, education, and safety. This cluster emphasizes the role of qualitative research in safety and leadership in nursing. Qualitative research related to such as education, critical care, COVID-19, and primarily healthcare aims to enhance nurses' leadership skills and safety practices. Quality of care and safety are also important components of this cluster. Green cluster's topic is communication and medication safety. It focuses on the importance of communication and team working in nursing education. Content analysis highlights topics related to medication safety, nursing homes, and nursing students, embracing the development of communication skills and teamwork during the educational process. The blue cluster is emergencies and risk management. This cluster encompasses topics directly related to patient safety. Subjects such as emergency departments, the role of nurses, medication errors, risk management, and safety culture are included in this cluster. Focus groups and qualitative studies also emerge as important factors in ensuring patient safety. For the yellow clusters, topics is that quality improvement and primary care. These clusters include studies aimed at improving the quality of healthcare services. Primary care, general practices, hospitals, and quality of healthcare. And quality improvement reflects the endeavors to enhance the quality of healthcare and patient safety. Adverse events play a significant role in hospitals and primary care services. The last cluster is purple cluster. Its topic is acute care and safety culture. This cluster encompasses topics related to acute care and nursing. Safety culture is an important part of nursing practices and plays a critical role in developing strategies aimed at enhancing patient safety. Overall, visualization based on authors' keywords was performed to identify trend topics. You can see yellow keywords reflects trending topics. The keyword threshold was set to 10 in the analysis. The network consists of a total of 32 keywords, 5 clusters, and 22 links. According to analysis, recent trend topics include safety culture, acute care, and COVID-19. So, this thematic analysis demonstrates how different areas in nursing patient safety are interconnected and how each area contributes to enhancing patient safety. Each cluster gathered around a specific theme, addressing various aspects of healthcare services. Thank you. I'm finished. Thank you. Do you have any question?
Thank you very much. Any questions? Okay, so this was our last presentation. So I kindly ask everyone to turn on their camera to take a photo. So please turn on your camera. Let's take a photo together. Okay. So please turn on your camera. Okay, so I would like to make an announcement. So UCG is organizing the 15th American Healthcare Hospital Management, Nursing and Patient Safety Summit from May 14 to 16, 2025 in San Francisco, US. The 15th World Nursing, Healthcare and Patient Safety Conference from July 25 to 27, 2028 in Holiday Inn, Dubai. and the 15th International Nursing, Healthcare and Patient Safety Conference from July 25 to 27, 2025 in Holiday Inn, Dubai. I hope we will meet again with new research and innovation in the field of healthcare. So it's been an honor to be among such accomplished individuals and to be able to present my perspective before you all. Thank you very much, and good evening to everyone.
Thank you.